Good afternoon, everyone. First, I would like to thank the organizing committee for inviting me to this meeting. Today, I will focus on the similarities and differences between the international and Asian HIV guidelines. I have nothing to disclose. Here is an outline. We will start with the timing of ART and then what to start. I will cover the first line, second line, and also the alternative first line regimen, and then we will go with ART transition in a setting of viral suppression and pre-exposure prophylaxis or PrEP regimen in Asian country. So I would like to start with the HIV burden in Asia and Pacific region. This report from UNS in 2020, there are 5.8 million adults and children estimated to be living with HIV. Of this, in this year, 240,000 new HIV infection and 130,000 HIV-related deaths. Among this population, 64% of adults on ART and 81% of children on ART. Since there's about 50 countries in Asia, so in this presentation, I will focus on the guideline from the countries that have high prevalence of HIV. This graphic shows the number of people living with HIV in 2020 in this region. For example, in China, they have 1.25 million people in HIV, and you can see in the dark brown color, which the number of people living with HIV more than 140,000. For example, in India, Thailand, Vietnam, and Indonesia. For about the when to start, all Asian country guidelines have implemented the treatment for all regardless of CD4 policy by uptake the WHO policy. You can see in this figure that show in the green that all in the country in Asia have adopted the WHO treat for all guideline, and this is lead to significant rise in the number of people being treated on the ART. For the type of ART, in the HHS US guideline recommend initiating ART at the time of diagnosis when possible, or soon afterwards to increase the uptake of the ART. WHO also recommend the rapid ART initiation within 7 days after confirmed the HIV diagnosis and clinical assessment, and also recommend the same-day ART should be offered to people who are ready. In Asia, all the countries already implement the rapid ART initiation within 7 days in their country. And some of the country also implement the same-day ART. For example, in China, India, Japan, Laos, PDR, Malaysia, Philippines, South Korea, Thailand, and Vietnam. For the timing of ART for adults being treated for HIV-associated TB, since 2010, the WHO has recommended to start ART within 8 weeks of the initiating of TB treatment, and in 2013, the WHO recommend to start within 2 weeks among those who have CD4 less than 50 copies per mil. But in 2021, the WHO recommend the ART should start as soon as possible within 2 weeks initiating of TB treatment, regardless of the CD4 cell count. So in this recommendation has been updated in the HIV guideline in many countries in Asia, such as Thailand, India, and Vietnam. For the what to start for the first line ART for adults, the DSSS US guideline recommend the big FTC TAF and DTG FTC abacavir or DTG FTC or 3TC plus TAF or TDF, or 2 drug regimen, DAGG and 3TC, in people who live in HIV who have a baseline ART less than 500 copies and without the hepatitis B co-infection. But this should be except for the person who the result of HIV testing resistant or HIV testing are not yet available. But for the WHO, the preferred first-line regimen is DTG plus TTC or FTC plus TDF, which is have been adopted by many countries in Asia. So the first line in the similarity of the first line in Asia and international guideline is the DTG-based regimen combined with FTC or 3TC or combined with TDF or TAF. In low middle income country in Asia also transitioning to TLD, the fixed dose generic combination between DTG, TTC, and TDF for their first line regimen. So the differences between the guideline is in Asian guideline, the combination of BTAF and DTG, TTC, abacavir, and two drug regimen was not recommended yet. But among Asian countries, there are some countries that have been recommend this regimen to their first line. For example, in China, Korea, and Japan also recommend this regimen in their first line ART. For the comparing integrase inhibitor for first line ART, this table shows the advantage and the disadvantage of each integrase inhibitor. For the bictegravir, advantage is their combination in a single tablet regimens one daily with FTC and TAF, and bictegravir also have high barrier to the resistance. But the disadvantage is the interaction with 3B drug, which is we cannot use with a patient who have rifampicin treatment for TB, and only available as a single tablet regimen, so we don't have the separate pill. Limited safety data in the pregnancy, so not recommend in pregnancy right now. For the dolutegravir, advantage is the generic fixed dose TLD that have been available in many low and middle income countries, and the dolutegravir also have combined with 3TC or 3TC abacavir, and also available as a single agent that we can be used with other NRTIs. Fewer drug off-with interactions, high barrier to resistance, and dolutegravir can be used with rifampicin. And the updated guideline has been recommend the preferred option. They recommend the dolutegravir for preferred option for pregnant person and person who trying to conceive. I will show you additional data on the dolutegravir in pregnancy in the next slide. And the disadvantage of dolutegravir, as we know, is a body weight gain and also the drug interaction with the metformin. For the raltegravir, the raltegravir has longest experience of use and fewer drug food interaction, and has been a preferred option for pregnant persons. But the disadvantage of the raltegravir is that there is no single tablet regimen, so it's multiple pills if you use the raltegravir. And compared to bictegravir and dolutegravir, raltegravir have lower genetic barrier to resistance, and also the twice daily dosing is a disadvantage. For the abacavir, the advantage is this is a single tablet regimen once daily. But the disadvantage is this have to be combined with boosted COVID-19, which is leading to drug-drug interaction. So this updated data from the Sivaporn study on the neuroacute defect prevalence among DTG in Botswana. This data presented as ACE Conference 2020 show the risk of neuroacute defect has declined to approximately about 0.2% in 2020, which is compared to the initial analysis at in 2018, which is the rate is quite high, about 0.9%, and but by the time the rate was decreased to 0.3, and the latest is 0.2%. So, which is not statistically significant different from the risk of women who were on other ART regimen at the time of conception. For the alternative first-line ART regimens, DSS guideline recommend the other two others two NRTI such as elvitigavir and raltegravir, and also boosted darunavir and atazanavir plus 2 NRTI, and also NRTI plus 2 NRTI in a fixed dose regimen such as doravirine, efavirenz, and ripivirine. And for the WHO guideline, the alternative first-line ART regimens is TDF plus TTC and efavirenz 400 milligram. And others regimen also can be used in special circumstances. For example, for maybe consider for people with established osteoporosis and or impaired kidney function. For the Asian guideline, there are similar guidelines to WHO. In terms of current role of boosted PI as the first line ART, some situations that boosted PI may consider as the first line. For example, that ART that need to begin urgently before the resistance test results are available, or if the patient have high risk of poor appearance. And the fixed dose combination boosted darunavir with TAP and FTC is also available as single tablet regimen in few countries in Asia, for example, in Japan. And what is the role of NNRTI as the first line regimen right now? The situation that may consider NRTI as a first line ART, which is patient may experiencing AE with integrase, for example, weight gain or CNS AE. And NNRTI also available as single tablet regimen with TDF, TTC, either efavirenz, ripivirine, or doravirine. And ripivirine have a variable outcome rapid profile, and doravirine was not associated with a weight gain compared to efavirenz or boosted darunavir. And for the second line and the third line ART regimen for adult, WHO recommend the second line the NRTIs plus DTG. The second line regimen will be 2 NRTI plus boosted atazanavir or lopinavir or darunavir. And the third line regimen, if you fail this second line, will be the boosted darunavir with twice daily dose plus 1 or 2 NRTIs and plus or minus DTG twice daily dose. And for the first line regimen with 2 NRTI plus efavirenz, the second line should be the 2 NRTI plus DTG, and the third line should be 2 NRTI plus boosted PI minus or plus DTG twice daily dose, which is similar to Asian guidelines. And for ART transition in the setting of viral suppression, optimal ART regimen can be considered in the following circumstances. So that for simplification, by reduce the number and tablets and dose frequency, switching to long-acting injectable formulation to reduce the drug burden, improve that tolerance by reduce the short-term and long-term toxicity, also preventing a drug-drug interaction and optimization of ART for pregnant, and also the reduce the cost. And for ART transition in the setting of viral suppression, PSS guideline also recommend 3 drug regimen, either same class or different class. Also recommend 2 drug regimen, which is DTG, TTC, or DTG ripivirine. Also recommend boosted darunavir plus TTC. And the long-acting ARV injectable cabotegravir and ripivirine also recommend either once monthly or the last update in for the FDA approval on the March this year have already approved the every 2 months regimen for injectable cabotegravir and ripivirine. But the patient have to have a stable ART and have HIV viral load less than 50 copies per ml and no history of treatment failure or resistance. For the WHO, in terms of the AIT transition, the WHO suggests consider for replacing equivalence-based first-line regimen with DTG-based regimen, and while we maintain the same NRTI backbone, but the long-acting ART is not recommended. That is similar to the Asian guideline that many countries have transitioning their first-line regimen to TLD, and no long-acting ARV is recommended right now. This figure show the data from PEPFAR Asian Regional Operation Plan in 2021. There's many countries in Asia are transitioning to the TLD regimen. For example, in India, Myanmar, Thailand, Cambodia, Philippines, and Indonesia. For the PrEP regimens in each guideline, for CDC PrEP 2021 recommend oral TDF-FTC or TAP-FTCs, and also recommend the injection of 600 milligram of cabotegravir or CAB every 2 months, which is the oral within is optional for 4 weekly in per the injection. For the WHO guideline recommended oral PrEP containing TDF, and in 2021, the WHO also added the dapivirine vaginal ring should be offered as an additional prevention choice for women. For the dapivirine vaginal ring PrEP delivered through the vaginal in the vagina, this is an NRTI that have active PrEP efficacy. And this vaginal ring should be provided as an option for women who are unable to take or don't want to take the oral PrEP. And for the Asian guideline, most Asian countries adopt the WHO recommendation on the oral PrEP TDF into their national guidelines by 2019. But I didn't see any country have recommended dapivirine vaginal ring in their national guideline yet. For the adoption of the WHO recommendation on the oral PrEP into national guideline in Asia, this figure shows the country that adopt or not adopt or pending for adoption the guideline. For the blue color represent the country that not adopt the haven't adopted the PrEP guideline into oral PrEP guideline into their national guideline. For example, in Japan, Indonesia, and Bangladesh. And the yellow color represent the country that pending adoption or was defined as planned to adopt the recommendation in next 2 calendar years, which is include China, India, Laos, PDR, Philippines. China has approved TDF for HIV prevention since 2020. For the green colors represent the country that already adopt the oral PrEP guideline to their regimen. For example, in Thailand, Myanmar, Cambodia, Vietnam, Malaysia, and also South Korea. So this the take-home messages is ART initiation should and regardless of CD4 cell count and rapid ART initiation is recommended in all Asian countries, whereas same-day ART has been recommended in some countries. And DTG-based regimen is preferred first-line regimen in all Asian countries right now, and many countries in Asia are transition the TLD to their first-line regimen. There is no long-acting ART is currently recommended in Asian guideline for HIV prevention or treatment yet for now. And the majority of Asian countries have been adopted the WHO recommendation on the oral PrEP into their national guidelines. Here is my summary of reference that I have been reviewed for this presentation. So I would like to stop my presentation here and happy to take any question. Thank you.